Hi everybody, welcome to this week's CBP Nonprofit Research Video Review. I'm Dr. Deed Harrison. I've been going through our CBP research publications in relatively historical order, but I've been kind of cherry picking the ones I want to cover each week. We'll be doing these for an awful long time. Chiropractic BioPhysics Nonprofit Research Foundation has sponsored and published over 150 peer-reviewed research articles. You can find these papers by going to the web link that was on the previous slide. We've been in a variety of the top spine journals and chiropractic journals in the world. And I've found over the years that chiropractors and medical doctors don't necessarily read the entire full text of our papers. So what we found is maybe perhaps more relevant is to go through them in a research video format using a PowerPoint presentation where I walk you through and moderate the study introduction, the background behind it, the methods, the results, and the clinical implication. This week I've chosen one of our historical papers from 1998. This particular paper, when it came out, it was very, very sophisticated, and it was an important project at its time. Still today, almost 20 years later, it is still one of the top papers in its respective field that's out there. The reason is it's how we approach the problem of investigating the differences in X-ray alignment in low back pain. We didn't just use clinical X-ray measurements, we physically, specifically modeled the spine with different types of ellipses to see if there was a difference between normal subjects and different low back pain subjects. So let's dive into this week's project, and then I'll give you a historical background as well. So this was in 1998, the Journal of Spinal Disorders. Okay, the title of the paper is Elliptical Modeling of the Sagittal Lumbar Lordosis and Segmental Rotation Angles as a Method to Discriminate Between Normal and Low Back Pain Subjects. 1998, Volume 11, Number 5, page 430 through 439. Now last week we went through our normal subject CBP elliptical model. That project was the first paper to physically model subject spines, normal subjects, with a piece of an ellipse. Now this week, this builds on that project. This looks at a different type of validity. Can the model discriminate between different types of subjects? A normal subject without a condition like low back pain versus a subject group that has a type of low back pain, like chronic low back pain without disc herniation, so no leg pain, right? Or pain only into the buttocks and groin area and then up towards the mid-lumbar spine. Also, maybe an acute low back pain group that has had pain less than 4 to 6 weeks. Also, maybe a chronic pathology back pain group. So we have a group that has chronic low back pain, but they have various pathologies in their lumbar spine, like a disc herniation, a retrolisthesis, a spondylolisthesis. So let's look and see, can we identify distinct salient features between these groups in their X-ray alignment and their elliptical model. So first and foremost, let's look at low back pain. This is something that's really, really frustrating in the literature. Different people have different perspectives, and everybody's a damn expert, right? Especially with the internet. Everybody's an expert. Well, you know what? Not everybody is an expert. You hear things like this, oh, don't worry about low back pain. It goes away on its own. You'll be fine. Now, some simple low back strain and sprain, like you go out and you overdo it and you haven't exercised and you chop a cord of wood, okay? Yeah, you're going to be a little bit sore for the next probably 3 to 4 days, maybe 5 days. That's going to heal up, okay? However, when you truly acutely injure your low back, it may not actually just go away on its own. Let's look at where this came from, and let's look at the reality of low back pain as a disorder. Number one, if you read some of the early works in the surgical and physical medicine literature, you'll find out that it was common to say low back pain went away on its own. Don't worry about it. So it says here, the majority of low back pain was considered to be just a simple acute injury that would remiss on its own with or without treatment. No big deal. Just wait it out, right? Well, where does that come from? Well, one of the earliest things in the literature comes from a guy named Dixon, okay? The Dixon paper has been referenced for probably 20 years including in the chiropractic literature, in guidelines developed for chiropractors by chiropractors, but not by treating chiropractors, by the way, by what we call doctors of the evening chiropractors. And if you know what I mean out there, you get the point, right? So there's guidelines that came out about a decade ago. These were started. They're called the CCGPP guidelines. Now, these guidelines referenced this Dixon paper, we'll call it a paper, we'll see where it really came from, saying that don't worry, the majority of low back pain is self-limiting. You don't even need to worry about it, okay? Pain levels decline on their own over time. That was from the CCGPP guideline that is still being used today to cut or limit chiropractic claims where they're treating low back pain patients under different insurance policies, okay? And you out there, you know what I mean by this. The chiropractors that are out there and patients that are out there, you're like, why did my claim get cut? Why didn't my claim get paid by my insurance carrier? Why did they say this wasn't medically necessary? Well, this is the relevance or the reality behind this. Okay, so it says down here, one of the original articles to which the self-limiting nature of low back pain dogma can be traced to is from Dixon. Dixon et al. claimed that 90%, 9 out of 10 people with low back pain, it's self-limiting. It goes away on its own, no big deal. Okay, we'll look at the Dixon paper coming up in a minute, but let's look at how this paper has been used. White and Punjabi in their 1990 textbook, one of the most famous textbooks of all time on spine biomechanics. A.A. White, famous medical doctor, great, brilliant researcher in the spine, and then none other than M.M. Punjabi, who is probably considered one of the founders of spine biomechanics. It's, huge name, many hundreds of publications, now retired. He is truly an established expert in the field. However, experts make mistakes, okay? Now let's look at this. Nachemson, the late Alf Nachemson, also very famous MD, PhD, the founder of the biopsychosocial model in medicine for low back pain. Bio means biomechanics, biology, psychology, and social all interact with this low back pain disorder. These experts, misquote Dixon. They claim 90% recovery of acute low back pain episodes. This is based on a record review in general practice. Now let's actually look at the Dixon study. Of interest, the Dixon study is not even a study, it's a lecture that was given at a research conference. Wasn't even a peer-reviewed project, it was a lecture. Number one, if you're a researcher out there, you go, oh, this is a problem. Yeah, Houston, we've got a problem. It was a presentation given, an invited presentation. It's not actually a study, it's a lecture with no data at the British Association for Rheumatology and Rehabilitation, their annual meeting in London in 1973. Dixon actually didn't do it himself. Dixon referred to Fry. Okay? In a separate lecture, not a study, a separate lecture, here's what Fry stated. Okay? So Fry's the origin of this, referenced by Dixon in another lecture that was then picked up by White and Punjabi and Nachemson, that was also used in the chiropractic literature and guidelines. You guys getting the idea how this works. Here's what Fry said. In an average general practice each year, that's an average medical doctor's general practice, 125 patients could be expected for soft tissue, rheumatism, or acute low back pain. Rheumatism doesn't mean rheumatic disease. They meant it as inflammation of the low back tissues causing low back pain. Of these 125 patients from this provider's yearly practice, 50 would likely be suffering from acute low back pain, 25 from acute neck pain. 44% of the patients with acute low back pain will lose their symptoms in less than a week, and 82% in less than 4 weeks. So number one, the 90% recovery, that's rounding up a little too much. Number two, if you actually look at this lecture, here's what they did. This is a retrospective review of records from a general practice. What happens is this. Okay, let's just say I got 100 people with acute low back pain that come to my office. Okay? If I look at this, 100 subjects, according to this, 80 to 84% or 80 to 82% of these subjects are expected to start to recover in 40 weeks. What is recovery really based on? Here's the reality of recovery. They didn't show back up for another appointment, and they call them recovered. So you came in, and the doctor says, oh, you got this, and he gives you some medication or whatever, and if you don't come back, he assumes that you're recovered. Do you find a problem with that? Yeah, I do. Probably the people that didn't come back, they're like, this sucks, I'm still hurting, I'm not going back to that quack because he just gave me drugs. You guys get it? This is a problem. So from 1970 all the way up, it's still being used today to claim that low back pain improves on its own. From a retrospective records review of people that never showed back up. That's the worst type of study design in the history of study designs. I'm here to tell you that. Let's look at what the actual natural history of is. It's kind of scary. Investigations into, true prospective longitudinal follow-up studies have identified that up to 75% of subjects with acute low back pain will continue to have problems. Look at this. At 3 and 12 months follow-up, only 21%, and 42 out of 170 means 25% in different studies of low back pain patients will be recovered. Now this is out of my lumbar rehab textbook in chapter 1. My lumbar rehab textbook was written in 2007. I don't have these ones referenced, but you could look it up. I have this one referenced. This is probably the most important one. At the time when this came out, this was one of the biggest studies ever done with one of the longest term follow-ups ever done, a 25-year follow-up of thousands of finished metal workers. Here's what they found. At 5-year, 10-year, and 28 years follow-up in a finished metalworking population, here's what happens. Initially, 54% of these subjects had low back pain and 25% reported leg pain. At the different follow-ups, 5-year, 10-year, and 28, I said 25, 28-year follow-up. Here's the percentage of those people still suffering. 75% of the initial group that had low back pain at 5 years is still suffering. 73% at 10 years. 88% at 20 years still have low back pain. It doesn't go away on its own. The natural history of low back pain kind of sucks. 28 years later, you still got it, right? This is really a frustrating thing. Now, clinicians, we try to minimize things because we don't want patients to be scared of it. You don't want to tell a patient, right off the bat, hey, Ben, you got back pain right now, and the good news is you're going to have it 28 years from now. You can imagine that would probably scare somebody, right? So you got to kind of tailor this down. You got to, try to explain the risk factors, and you got to mitigate problems with the patient. But you also don't want to, totally dismiss it and go, oh, don't worry, it goes away on its own. It doesn't. Look at this. Low back pain in children. Here's the scary thing. Now, I'm a father. I've got 2 kids. I've worked on many, many hundreds of children in my practice. Here's the references. You could look up these authors. You can find them. Look, 1999 European Spine Journal. What happens is when you have low back pain as an adolescent or a teenager, that's a risk for low back pain into adulthood. You got low back pain as a kid, chances are you're going to have low back pain as an adult. This is a problem. Look at this. 25-year study out of Spine, 1995 by Harraby et al. Positive correlation for low back pain in adolescence translating into low back pain 25 years as an adult. So now you're in your mid to late 30s or 40s and you still got it. It doesn't go away on its own. This is a problem. It's a crisis. You don't minimize it by saying, oh, 90% of acute low back pain episodes go away on its own. They don't. It's absolutely, actually almost the exact opposite of that. Almost 70 to 80% of low back pain acute now means you're going to have risk factors for low back pain into adulthood. Why? Well, nobody figured out what the heck was going on. That's my perspective. Now, there's different models. If you listen to what I said with the Alf Nachemson, MD, PhD, brilliant researcher. And please understand, while I'm kind of ripping on those guys for what they said about acute low back pain, they are truly experts in the field. They're pioneers in the field, and they've brought forth many, many innovations and insights into low back pain, and they've fostered, a number of researchers, etc. I get that. However, this idea of back pain going away on its own, no way. Totally opposite of what's in the literature. Biopsychosocial model. Bio means biology and biomechanics. Psycho means upstairs in your mind, and social means how it's perceived and how you interact with, your friends and your family and things like that. There's multiple aspects for low back pain. There's also diet, right? There's what you eat, environmental toxins. But if you look at the words biopsychosocial, what's first? Well, is it because B comes the first in the alphabet, or do you think biomechanics, biology probably takes the biggest role? This is the issue. When somebody has big time risk factors for low back pain, whether it's acute or going into chronic, you better figure out the problem with the biomechanics. That's what this week's study is all about. And I know it took me some time to get there. Here's what we did. We took 4 groups of subjects. We took 50 normal subjects from our previous paper. Okay, these are people without low back injuries, without low back tissue damage, no x-ray disc degeneration, no bone spurs, no anomalies, things like that. 50 of them. We then matched them by age and weight and height and sex to 2 different low back pain groups. A true chronic low back pain group and a true acute low back pain group. Okay? Now, in the acute and chronic groups, they didn't have x-ray pathologies yet either. So this is a really good project. We're eliminating x-ray pathologies in these 3 groups: normal, chronic, and acute. Then we have a 4th group. This 4th group is chronic low back pain with a conglomerate of problems with their low back. They've got disc herniations, they've got retrolisthesis, they've got anterlisthesis, they've got bone spurs, they've got pathologies. So they've had a bad back for a long time, right? And then what we're going to do is do upright static equilibrium x-ray analysis on their low back, and we're going to look at, can we identify salient differences with their x-ray alignment, segmental total angles of curve, and elliptical modeling. The elliptical modeling is the important part for me in this project. This had never been established before or looked at before. Okay, so here's the methods we use. Segmental angles, relative rotation angles at each segmental level. That's using the back of the bodies. We used the total angle of curve L1 to L5. We also looked at T12 to S1 as well. We looked at the sacral base to horizontal. We looked at how much translation T12 relative to a vertical line at S1 we have. And then we did what we call different Cobb angles. Inferior end plate of T12 to the sacral base. And then we did L1 to L5 Cobb angle as well. The important part of the modeling project is we looked at our elliptical model and its B over A ratio. So we took the subject spines, we digitized them into an x-ray computerized system, or their x-rays into a computerized system, and then we did curve fitting like we talked about last week, least squares error analysis. Here's what we identified, the results. The normal subjects, their major axis of the ellipse, okay? That's the long axis of the ellipse. Let me back up. That's A right here, the long axis. That's 157 millimeters. The acute back pain, 160. Chronic, 174. Pathology, 165.5. Now, the reason we have to match these subjects for age, weight, height, and sex is because if I don't match these groups for height, I got a problem when I'm looking at millimetric values, right? Certainly. But the ratio would still be, if I looked at the ratio of B divided by A, which is coming up, that ratio is not necessarily height dependent, right? But one measurement would be like this. But our subjects are matched, so we look at it, we go, there's statistically significant differences between these subjects and their major axis length. Here's the minor axis, B. There's statistically significant differences here. Look at the normal subjects versus the chronic pain. That's a big time difference. What does this really mean? Well, you'll see what it means is the ellipse in the chronic pain is flattened out. It's squashed. They don't have a deep enough elliptical curve. Here's the ratio, the B over A ratio. 0.39 in the normal subjects, 0.27 in the chronic, and 0.3 in the pathology. Now of interest, from from the inferior body of T12 to the top of S1, the acute low back pain subjects actually look like they have a flattened ellipse too. However, if I include the whole sacrum and the whole T12, we'll see it's a little bit different, but that's coming up, okay? So right here, elliptical ratios, the B over A ratio, statistically significant differences. Now, look at the least squares error. How accurately can we model these subjects? What you'll notice is the normal subjects have the smallest least squares error. This is important. This means these are the ones we could actually fit with an ellipse. The other ones have an altered shape and they can't quite be fit as accurately. Now, it's close, right? 2 millimeters, 1.96, and then the pathology group, quite a bit of a difference. But you get the idea. There's differences in these subjects' elliptical models, and these are statistically significantly different. Now, it's hard for a clinician and a patient to take this data and go, wow, what does that really mean, and extrapolate it into clinical variables. However, the mathematician and the engineer and the researcher, I look at that and I go, wow, that's a big deal. That's clear differences. For the first time ever, somebody's actually modeled differences between matched groups of subjects. It had never been done before. Taking a validated model and showing that there's clear, concise differences between these subjects. There's a reason these people have low back pain, right? It's not just psychosocial. It's bio and then psychosocial. Here's the angular measurements and then our H over L. I'll show you what the H over L is in just a second. Okay, now segmental angles, relative rotation angles, normal, acute, chronic, and pathology. If you go all the way down, you start to see distinctive differences, specifically all of a sudden right in this lower lumbar region, you start to see some differences. If I look at the total angle of curve, the ARA L1 to L5, okay, total angle of curve, 40 for the normal and 40 for the acute, not much of a difference. However, big difference between the pathology group. My chronic low back pain group. I'm 25% reduced in my lumbar curve. There's a clear difference in the pathology group. Now, while their ARA looks a little bit bigger compared to the chronic back pain, you have to realize, if I go back to this modeling data, we had a harder time modeling these subjects. They have an altered fit of their lumbar curve relative to an actual ellipse. So while it doesn't show a big difference with the total angle of curve L1 to L5, 5 degrees off, it's still quite an abnormal configuration. It can't be modeled with this ellipse. That's why it's important to have the modeling data. Now, Ferguson. Ferguson is the sacral base to horizontal. Here's what we see. Normal is 39.4. Look at the acute. The acute is statistically increased. While their total L1 to L5 curve doesn't look like it's increased, the sacral base is increased and the T12 to S1 Cobb angle is increased. Take a look at the normal subjects. That's really driven by the sacral base. So what we see in the acute back pain, to clarify this, we see an increased pelvic tilt compared to the normal subjects and compared to the pathology group and the chronic low back pain group. In other words, the distal lumbar curve appears increased in my acute low back pain. It's decreased in my chronic low back pain and pathology group. Okay, so there's my clear differences. Here's my height over length ratios. The height over length ratios, what you'll notice, is H over L 0.96 in the normal subjects. The chronic pathology, the chronic back pain group stretched out H over L. That means a flattened curve. The pathology group, a little bit reduced in its height over length, but remember, we had a hard time modeling them. The curve couldn't quite be fit through them, so you can't necessarily trust that particular data. And then the acute subjects. The acute subjects overall have a reduction in the height over length index, meaning a deeper curve. Now, height over length, if I go to this, the length is the length along the total curve, this dashed area here. The height would be the total height along this vertical axis line. Okay, so we have a height over length ratio of a curve. Anytime I have a curved column, the H height divided by the L length is going to be less than 1. The deeper the curve, the smaller that H over L index is. The straighter the curve, the more, or the closer it approximates 1 to 1, okay? That gives you an idea of the H/L index. We also looked at statistical analysis in the form of what's called receiver operating characteristic curves, or ROC curves. Now, what ROC curves do is it looks at sensitivity and specificity. It's a big word. It means, true positives, true negatives, false positives, false negatives. Okay, so what we want is we want to see if our model or a value can actually identify the true positive low back pain and the true negative, the normal subjects. Okay, and we want to minimize false positives and false negatives. That's what we want to do. Of interest, the L1 to L5 value, looking at normal subjects and chronic low back pain in this population, here's what we identified. 36 degrees is my cut point. If I look at this number chart, each dot is one subject. 36 degrees is approximately here. If you're less than 36 degrees, you've got chronic back pain. Now, there are some subjects above that, okay? There's no such thing as a perfect cutoff value, but this is actually a very good cut point, 36 degrees. If you're less than 36 degrees, you're statistically in the chronic back pain group. If you're above 36 degrees, look at this, you're in the normal subject group, okay? That's the L1 to L5. Now down here, I don't have a graph or a picture showing you the T12 to S1 measurement, but you get the idea. Instead of L1 to L5, it's S1 and T12 vertebra up here. This is the lower graph. Now this graph is looking at acute back pain versus the normal subjects. The top graph was looking at chronic back pain and normal. Okay, we said 36 degrees is the cutoff. If you're less than 36, you're statistically in the chronic back pain group. This one, 69 degrees, T12 to S1. Look at this. If I find 69, I go, here's my acute back pain subjects versus my normal subjects. You can see clear cut points, or excuse me, normals on the top, and acute back pain is on the bottom. There's clear differences between these subjects' data. Okay, so this is how we look at cut points between the subgroups of back pain. Discussion. Our results are actually very, very similar qualitatively to a paper that was published before us 4 years earlier in Spine in 1994. Jackson et al. Took normal subjects, 100 of them, matched them for age, weight, height, and sex to 100 chronic low back pain subjects. These were adults. What Jackson et al. Did is they didn't do modeling, but they looked at segmental angle and total angle of curve analysis. What Jackson et al. Found in their chronic back pain group is very similar to what we found in our chronic back pain group. They found a loss of the distal lumbar curvature in their low back pain groups. They found clear differences in the segmental angles of curve. Not so strong differences in the total angle of curve, although they did find some, but they found striking differences in the segmental distribution of the curve, loss of the distal lumbar curve. Our paper is unique because we modeled these subjects. Modeling is a higher level of analysis. We also looked at receiver operating characteristic curves in a follow-up to that data, and that's in our 2007 CBP lumbar rehab book, chapter 7. We also presented that at a couple peer-reviewed conferences. Okay, so you look at this slide, this shows you the differences that we identified between different types of low back pain condition groups versus a normal group. Here's our idealized normal subject model. Their spine in this representative sample can be clearly fit by a piece of an ellipse, where I have a flatter portion of my low back curve at the top, increasing in its curve down at the bottom. That's what our elliptical model represents. B would be a pathology group. This is somebody that suffered chronic low back pain for a number of years. They have off and on intermittent leg pain, and look what they have. They have a very abnormal low back curvature. They have segmental displacements where these lines don't line up. The black lines are jagged and displaced. Those are retrolisthesis. There's disc damage. These people have a flattened lumbar curve on average, and they have a very, very abnormal low back shape. It can't typically be modeled with an ellipse. It's altered in its geometry. And then C, ignore the spondylolisthesis down here. qualitatively see is kind of like the acute low back pain group. Acute low back pain group has too much curve at the bottom, too much curve at the distal lumbar curve. This likely is reflective of muscle spasm or an inability to really adopt a proper pelvic shape. Now, I'm not talking about a disc herniation case. Don't get this confused. I'm talking about what we call non-complicated acute low back pain, meaning there's not a disc herniation and there's not leg pain. These subjects typically have an increased low back curve. And then D and E are types of chronic low back pain group without the major damage yet to their lumbar spine. These people can have disc bulges but not true herniations yet, right? These people have really abnormal low back curves. They have the start of mild degenerative changes. If you let them go, they're likely going to turn into the group that's in B. These people are going to end up with chronic damage, long-time problems, etc. Our modeling data shows that we can clearly discriminate between these populations of subjects. The model is valid in as much as it can distinguish between a normal subject's spine, an acute subject with low back pain, a pathology group, and a chronic back pain group. This is a very important piece to the puzzle. Conclusion: we successfully modeled the normal subject, their lumbar curve, with an ellipse. We did segmental and total angles of curve. That's the normal. We identified statistically and clinically significant differences between 3 subgroups of low back pain. Shown here is one of them, the pathology group. Altered configurations of this elliptical model may clinically correlate with the development of future degenerative joint disease and specific types of low back pain. That's what we said in 1998. Today, that's exactly what has been found. If you look at some of the recent studies that have come out, and I might go through them in the future with you, that's exactly what's been found. It's been identified the subjects that have a loss of their low back pain or low back curve, they're the ones that get degenerative joint problems. They're the ones that have long-term suffering, right? This early project actually, suggested that would be true, and it has been validated across different studies that are well done that have come out in the last decade in spine research. This study is very important. If you're out there and you have acute back pain, you know what? You got to take it serious. If somebody says, "Oh, don't worry, watchful waiting, it'll go away on its own." Absolutely not true. You might be the 1 out of 4 people that happens to, but other people, you got to be highly concerned about this. You've got to control risk factors. You got to change your diet. You got to change your exercise, perspective. You got to make sure you get to somebody that analyzes your spine appropriately and identifies risk factors for these things, because you don't want to be the 3 out of the 4 that suffer for 28 years. You got to take it seriously. If you take it seriously, I personally believe that you can prevent that problem from happening, but you got to control the risk factors. If you're a chronic low back pain subject, you know what? Don't sit there and go, "Hey, you know what? There's no answer for me." There absolutely is an answer for you. You have to find out exactly what's wrong, and you have to nip it in the bud, and you have to do things to correct your spine. You might have to exercise. You might have to lose some weight, and you will have to get specific spinal corrective care to reestablish the normal lumbar lordotic curve that should be in your spine. If you're somebody that has the chronic pathology, man, it's really difficult for you, I know. There's not a lot truly in terms of 100% correction that can be done. However, there is still a lot that can be done. You can improve some of this alignment. You can stop it from getting as bad as it could if you did nothing about it. So don't just sit there and go, "It sucks to be me." Don't do that. You can still be proactive, and you can, play the cards that you're dealt and play them right. That's the moral of the story. Okay, hopefully you've enjoyed this week's presentation. You can see I get a little bit excited about this topic. It's very dear to me. I've worked on thousands of patients in my career, and I can tell you that, my interpretation of this comes from working on people and comes from the research, right? Clinicians, we need to do a better job to help those people out there. But if you're one of these people out there that has this condition or any of these conditions, you got to do something too. No clinician can heal you. You've got to do it. You've got to put in the work. work. You got to put in the effort. Don't just pop a pill and expect your back to get better. It doesn't work that way, right? That's a crutch. A crutch is only used to get you through something. There's things that you can be done. Most of the time, we can find a way. If you've enjoyed this, hopefully what you can do is please consider watching the rest of this presentation, supporting CBP nonprofit research, and also identifying a CBP trained chiropractor in your area, because I guarantee you they can help you. Until next time, I'm Dr. Deet Harrison. Thank you for your time and attention. If you like this information, if you're a patient, you need to go to a Chiropractic BioPhysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy-to-use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work, okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP nonprofit will get 0.5% of all your purchases, which is a big deal. It adds up.